So I think we can start now. It's 8 p.m. in Buenos Aires and Brasilia. I'm Carolina Prando. I'm the head of the Educational Committee of the Latin American Society of Immunodeficiency. And it's a great pleasure to be here today with Cecilia Poli and Alex Prado. The topic for today's webinar will be the function assays in autoinflammatory inborn errors of immunity. So we'll start with a clinical case that will be presented by Alex, and then Cecilia will give us a talk about autoinflammatory diseases. So before we start, we have a couple of announcements, just a few, don't worry. So I saved the date for the LASID meeting. Actually, not only a save the date, but go make your registration because we have special prices for June and July, and then in August the prices go up. So don't forget to register as soon as you can. We are preparing it with and it will be really good to see you all in person there. Also, we have the deadline for the abstracts for LASID meeting that is June 30th. So you have 5 days to submit your abstract. You can point your cell phone there, and for the QR code, you are redirected to the website where you can make your submission. We also invite you to explore and to submit papers for the Journal of Human Immunology. It's a new journal and it's dedicated to the field of human immunology and especially to inborn errors of immunity. So we have there the newest classification for inborn errors of immunity. The paper whose Cecilia is the first author, so you can find this paper there and much more. And almost done with the announcements. If you're not yet a LASID member, please join us. You can join LASID being a regular member, or if you are younger than 35 years old, or you are still in training in immunology, you can join us as LASID junior member. So Cecilia Poli, she's the secretary of LASID, and she's director of the Center for Translational Immunology in Universidad del Desarrollo in Santiago, Chile. She's also the chief of immunology and rheumatology in Hospital Roberto del Rio. And she's a PhD in immunology, the program that she did at Baylor College of Medicine in Texas. Alex is Brazilian. He's an allergist and immunologist at Hospital das Clínicas. He coordinates the infusion center at Clínica Croce. He also collaborates at the Secondary Immunodeficiency Clinic, and he's member of the Department of Inborn Errors of Immunity in our Brazilian Association for Allergy and Immunology. And that's it. So I hope you enjoy. At the end, we'll be showing you the 2 next webinars. So we hope you can join us for the next ones. And now we will start with the clinical case. So thank you, Alex and Cecilia.
Thank you. I'm sad because I'm not junior anymore. Jesus. Oh my God.
No.
Let's start. Okay, I hope you can see my slides, my presentation. So, hola a todos, ¿cómo están? Soy Alex Prado, inmunólogo y alergólogo, y la verdad que es que no hablo español todavía. Pero espero que para el LASID ya me defienda un poquito mejor. Quiero agradecer de corazón a doutora Carolina Prando pela invitação e dizer que é um prazer enorme estar acá em esta mesa com a mulher que mais admiro na imunologia, a doutora Cecilia Poli, Dr. Power, yeah. E agora vou fazer minha apresentação em inglês. Eles mostraram um caso clínico em la autoinflamatória, a enfermidade autoinflamatória. Espero que les gostem, que se divirtam. E graças a todos por estarem acá. So let's start with the case. I have no conflicts here, only that I do love this type of subject. So let's start with a clinical case. It's a old 9 years old girl, a patient that was referred to me by a colleague, a very dear colleague, from the countryside of São Paulo, Pirassununga, São Paulo, Brazil, with a story of urticaria and no parental consanguinity. I used to play because I do love this kind of pictures in EA generated. She didn't have clothes. She wore urticaria, yeah, if you can see here. But at 5 years old, we started the case with erythematous edematous itching, skin lesions involving trunk, abdomen, limbs, and later face, okay? With a variable duration, with a residual hyperpigmentation observed. And it was kind of stressing because it is a alarm sign for us. So, talking to her mom, we saw that we had potential triggers, including cold exposure. So, it was very related. So, a pediatrician initially started with elimination of food dyes and processed meats. Okay, it's kind of normal here in Brazil. It's bad, but it's good because it doesn't, it's not healthy, okay? But it started with antihistamines with a partial response. And I thought a little bold, but it was started after with a trial with a homalizumab with a limited efficacy comparing with the antihistamines. And the mom discovered something, and the patient started to feel better with steroids. So this was given frequently by his mother, by her mother, sorry. At 6 years old, the patient started with a new clinical picture with a recurrent fever. And sometimes during the fever, during the flares, with some upper respiratory symptoms, sometimes not. And now, on that point, they started, the doctor started to think in another kind of diagnosis, maybe CAPS, maybe an immunodeficiency. What's happening now? So at 7, things started to feel worse, if I can say this. The patient started with more prolonged respiratory illnesses, with frequent fevers, requiring sometimes antibiotics, and got twice a diagnosis of pneumonia, with a X-ray showing a bilateral infiltrated. After, with a chest CT scan, they saw bronchiectasis. Okay, it's not the patient, sure. I just put here to illustrate things. And after that time, they referred to an immunologist, not me, my colleague. And there, they saw something different. They saw a hypogammaglobulinemia, especially thinking in IgG and IgM. So in that moment, the fever she was having fever, skin lesions. They stopped omalizumab, okay, amen, yeah, and started to give immunoglobulin, thinking in hypogammaglobulinemia, okay. So that time, the infection episode came under better control. It's a good thing. So what? I use this picture because it's a very known picture around Brazil and Latin America. So what's happening here? It's a PID or a SID. It's a secondary immunodeficiency due to steroids, or is a primary immunodeficiency like a common variable immunodeficiency? Because we are seeing fever, but we have infection associated, we have a hypogamma. What's happening now? At 9, things like became more strange. So the skin lesions became more infiltrated, indurated, and painful. So she underwent a skin biopsy that revealed a dancing dermal infiltrated composed by neutrophils and macrophages with CD68 positive, with no vasculitis, with no immunocomplex. So, okay, it's not a vasculitis, yeah. And after that, she got an evaluation of an ophthalmologist because of eye redness and discomfort, and got this new diagnosis of anterior uveitis. That time, the abdominal pain started to like appear during the episodes of flares of fever. Then she had blood tests, and we can see here outside the crisis, outside these febrile episodes, we just see neutrophils a little increased, yeah, with IgM low, remembering that she was already getting a replacement of immunoglobulin, so it was normal, and with acute phase reactants normal at that time. But during the febrile episodes, we see a lot of neutrophils, and we can see the CPR and ERS increase it, okay? So let's connecting everything, these dots, this a lot of information that we have here. We are talking about a patient that started at 5 with urticaria, with alarm signs, hard to control, at 6 with a recurrent fever, at 7 with respiratory infections, pneumonia, and hypogammaglobulinemia, and after at 9, worsening of lesions, uveitis, and abdominal pain during the crisis. And put this everything together, she had neutrophilia and elevated acute phase reactants during flares. So we decided to part to the genetic test, and we got a panel and thank because it's not common, and this is why we're gonna hear Cecilia after talking about the functional tests, but now we had a positive genetic test. We found a mutation in this PLCG2 or gamma 2 that is related with a gain of function of this gene and is related applied or autoinflammation, antibody deficiency, and immune dysregulation, or applied depending on the place that is a familiar called autoinflammatory syndrome type 3. And I do love this because it's very interesting when you are talking about in this picture here, we're talking about functional class of applied. And depending on the mutation, depending on the place and the protein, we can see different phenotypes, a different spectrum of this. So if you have a morphic or hypomorphic mutation, we can see here patients with a haploinsufficiency, and it leads clinical pictures with infection, so herpes virus and NK defect and humoral immunodeficiency. But if you go to the middle, we see here, yeah, a mixed phenotype with a cold-induced hyperactivation, a unstable protein created in with this kind of mutations, these different mutations. And this is the patient with that we call originally applied patient. Yeah, this patient has usually cold urticaria. Okay, the patient can have a lot of other things like humoral immunodeficiency, granulomas, autoimmunity, etc. But what is predominant here and the main manifestation is the cold urticaria, and it can make a real mess with other diagnoses such as CAPS, for example. And we have hypermorphic mutations, that is the patient that we know with autoinflammation, and here is what we call applied. And I like this picture also because we have the gene here, and depending on the mutation, especially this one, P522R, in this regulatory domain here, it's a good mutation actually because interestingly, it can be protective in some conditions, okay? We know that this mutation has been associated with a reduced risk of late onset Alzheimer's disease. So we don't know why exactly. Maybe it is because enhancing microglial glial activity and amyloid clearance. So it's very, very interesting. And I like this picture also because we have here two antagonistic effects in applied. So at the same mutation here, we can see different clinical pictures and different phenotypes at the same patient. So in the panel A, for example, if you have this mutation, the S707Y, we have the increased levels of calcium here, and it will impair the function of B cell differentiation. And the patient will have low levels of B cell, and it can explain the hypogammaglobulinemia. But on the other hand, we can see in this panel B the same thing happening, but in the myeloid cells it can lead to the autoinflammation and hyperactivation and differentiation of macrophage granulocyte cells. So the same mutation, the different compartment, immunological compartment, we can see different things happening. And we need to know this protein because it's a very important protein in our sickness, in our health, such as wedding, for example. But in normal physiology, for example, we have the protein helping a lot in the development of the tissue. We have in B cells, T cells, NK, myeloids, and platelets, and even the bone remodeling. But on the other hand, the other side, we can see problems in this protein, the PLC gamma 2, that can lead to Parkinson, Alzheimer, immunodeficiency, autoimmunity, autoinflammation, etc., and even the resistance of some medications such as ibrutinib. And I like this picture because I did it, but I like to organize things, and I think it's very interesting to put together this manifestations and this umbrella, because we have applied and efficacy, and where we have the predominance of autoinflammation. On the other hand, we have the plight and CVID that the patient will the patient will lead with immunodeficiency and autoimmunity also. Okay. Usually in Brazil, when I teach, when I use some, I do like tables. I usually say Uncle Alex like tables because it can help us to organize everything. And I like this one because I just put together all the manifestations that are related to PLC gamma mutation. So we have a lot of diseases here, yeah? And it can help us to organize things and help the patient to get better. So how is she today? Now she's 11 years old. She's still using immunoglobulin in replacement therapy in 400 milligrams per deciliter each month. And the inflammatory symptoms now are controlled with canakinumab, 150 milligrams every 150 milligrams, sorry, every 8 weeks. Now she's fine. And the final message that I really need to share with you guys here is that the autoinflammatory really can present with another features like immunodeficiency. I remember when I started to study autoinflammation with classic syndromes like CAPS, hyper IgG, and etc. We are always concerned in autoinflammation, but now we can see and we can learn that some patients can also have immunodeficiency, so this is very important. However, the primary mechanism involves the regulation of the innate immunity, especially the inflammasome, but they can have also infections. It's important to remember that a single gene can lead to diverse phenotypes, as I showed you, depending on the affected domain of the protein. So it's very important to know this. It will help us with the prognosis and then therapy. So don't forget this. And using our friend Dr. House, it's not lupus. Take care. Sometimes it's not all caps. So we have at least 4 types of different cell diagnoses that we need to think when we see a patient with urticarial-like lesions, okay? And to finish, sometimes it happens. Genetics ghost me, and it's a time for plan B. So not every case came with a textbook presentation with a perfectly matched genetics, both easy to perform, to the interpretation. And so what do we do now? We cry, we lay in our bed. No, actually, this is exactly the reason why we are here talking about the functional testing. So I think that is the time the functional test comes into play. And now is the time of our Dr. Cecilia Poli talk for us about the functional testing in autoinflammation. So I really would like to thank you guys for your attention.
Congratulations, Alex. That was a fantastic talk. And it's perfectly timed because I'm not going to be talking about functional assays for PLC gamma. There is one, so I do want to comment on this after your fantastic presentation while I pull up my slides. PLC gamma, as you perfectly said, can have gain of function and also loss of function, and has also different functions. So that's a very complicated gene to do functional assays, because it really depends on what you think is going on with the patient,
Exactly, yeah.
how you choose the assay, what assay you do, etc. So, okay. Is that showing up correctly?
Yeah.
Okay, so with that, I'm really thankful and happy to be here with you all. Thanks, Caro, for the invitation, and thanks, Alex, for presenting that wonderful case that really nicely introduces the topic. So I have no disclosures, and what I would like to discuss today is autoinflammation and immune dysregulation sort of go together. And I'm going to make the case that the pathways a lot of times are similar between one and the other. So you don't really need different functional assays for both of them. Sometimes you can use the same, because if we needed a different functional assay for each single variant, it would be impossible with the number of growing disorders that we have. Incomplete penetrance is very important for immune dysregulation and autoinflammation. And this really, really urges functional assays in this specific group of inborn errors of immunities. And then so I'm going to talk a little bit, of course, of the functional studies and other strategies to establish pathogenicity. So for primary immunodeficiencies or inborn errors of immunity, we're far from like the first inborn errors of immunities that were described associated to infection. And it's really now the era of immune dysregulation. In the last update, more than 550 disorders were described. And as I briefly mentioned for PLC gamma, sometimes it's not one gene, one phenotype, one pathway, but it may be one gene, variable phenotypes, and even different pathways. So for one gene, you may need more than one functional assay, such as the case of PLC gamma. This is very important because this establishing a diagnosis, not only genetically, but also functional allows targeted therapies with monoclonal antibodies, small molecule blockers, or even gene therapy. So this is why these functional assays are really critical to not only make a diagnosis, but really establish early on the right therapy. And as I just said, it is the era of autoinflammation and immune dysregulation. I'm lucky to love these disorders since a while now, because these are the fastest and more growing areas in inborn errors of immunity. So there's a lot to continue to be learned. And as you saw, the paper just came up, but it's already outdated. So there's going to be more to learn in this year and next about these disorders, pathways, and different functional assays. As I briefly mentioned earlier, the limits between immune dysregulation, autoimmunity, and autoinflammation are increasingly blurred, to the point that when we wrote the update for the IUIS, really we changed disorders from one table to the other, because with different arguments, like how do you define what's pure autoinflammation and immune dysregulation? It's no longer that strict before, right? We used to think, okay, innate immunity is all autoinflammation, and then immune dysregulation is more cell mediated, but it's not like that anymore. And as I mentioned before, the pathways also overlap. So they may be clinically indistinguishable. The same pathways can be disturbed in both types of disorders, and the same pathways at the same time can be targeted. So I'm going to be talking a little bit about both today. So autoinflammatory disorders are classically defined as inflammosomopathies, rellopathies related to NF-kappa B, and interferonopathies. As I'm gonna make the case throughout my talk, this classification is also close to being outdated because there's other mechanisms that have been added to this list as new disorders have been described. And depending on the pathway they affect, of course, there's going to be different functional assays and different biomarkers. As I mentioned before, incomplete penetrance is very common in autoinflammatory and immune dysregulation disorders. Most of them are autosomal dominant. So when you study a patient and you find a variant of unknown significance, sometimes it is useful to sequence the parents and say, okay, parents, this is de novo, so most likely pathogenic. But a lot of times one of the parents carries the mutation and then you're really stuck because you can't say it's not pathogenic. And this is why functional assays are really, really needed. Different factors play into this incomplete penetrance. Of course, epigenetics can contribute. There's contributing variants in other genes that can contribute to this expression. Monoallelic expression is like a wonderful concept, very recently introduced by Dr. Bogunovich in his paper from Nature early on this year. And also additional mutations in genes that are encoding for proteins that interact with the mutated molecules. And such is the case of the HAC allele and STING in cases of incomplete penetrance of Copa syndrome. So when we discuss about functional studies, I want to really make the difference between functional assays to assess a dysregulated pathway and not necessarily demonstrate pathogenicity, but may support it. And this is what we can call biomarkers, depending if we're measuring it on the patient or in a cell line that we've transfected with a specific mutant. And under this types of assays are the interferon signature for interferonopathies and other disorders, AAT2 levels, inflammasome activation, IL-18 levels, and phosphostat1, STAT3, or STAT5. And then there's the functional assays we use to establish the pathogenicity of a gene candidate or variant. And this really requires transfection of the variant and the wild type and compare them into a specific cell line using whatever readout, depending on the gene, to really establish pathogenicity. And I really want to make this difference because if we find, for instance, a patient with a mutation in ADAR and they have a high interferon signature, that doesn't mean that variant is pathogenic. It just supports that variant being pathogenic. So I clearly want to make this difference. So when we want to describe new genes associated to inborn errors of immunity, we need to remember Casanova and Narangelo's criteria to define this new genes. And we have to consider the allelic frequency, the expression and function of the gene product must be impaired. And then the third criteria is to look at the functional impact, and it must be clinically relevant to the phenotype. And it has to be demonstrated either in a cell line or in an animal model, and it has to be recapitulated then. It has to be when you put the wild type allele in. So a little bit differentiating, right, pathway readouts from like real functional assays to demonstrate gene pathogenicity. Why do we care? Because there's targeted treatments. So we really, really need, we don't treat all patients the same. So we really, really need to assess pathogenicity to define what treatment is going to be best for our patient. So for interferonopathies that can be caused by the disruption of multiple pathways, such as the RNA and DNA sensing pathway, the proteasome pathway, or STAT1 or other stats pathway, they're all characterized by this expression of these type 1 interferons that we call the interferon signature. So this is a good readout for this disorders. But we do have to remember that if we have a cold or if we have other common states, we may have an elevated interferon signature not having an interferonopathy. So this has to be measured, separated in time, multiple times, at least 3 separated by a month when the patient is healthy, to really call it an interferonopathy. The interferon signature is differently dysregulated in different disorders. There's a spectrum, and there's also overlap. So it's a good biomarker, but as I said, will not certify pathogenicity. And here I've put some examples from this in silico paper of several disorders that are characterized by a high interferon signature, but you can see the variability, right? So it's sometimes hard when you have like one individual patient, and it is important to measure it several times in the same patient to really be sure that there is an interferonopathy. So this is from our cohort, and this is just to show you how variable it is. So in a SAVI patient, for example, it's really, really high, up to 75 times elevated. But in an ADAR patient, it might only be elevated 2 times. Some other AGS syndromes don't even have an elevated interferon signature. So it's really variable among patients. Although the interferon signature is really useful, it's only available in specific labs, research labs, and it's not really available clinically, which really hinders diagnosis sometimes of patients. And it's difficult to bridge that into the clinic because it's mRNA-based, it's expensive, and it needs a lot of controls. So cyclic 1 is upregulated by interferon type 1 signature in monocytes. And this has been postulated as a very good surrogate to measure the interferon signature in monocytes. So we've tried this in our own cohort, and there's really very good correlation, although there's also a spread in between the ISG score and the MFI of CD169 in monocytes. So this is a really good readout if you want to translate it into clinic and measure the interferon signature several times in a patient. But really, if you want to demonstrate the pathogenicity of a variant, what you need to do is not only measure the interferon signature in a patient, but also do the work in a cell line to prove the correlation between a specific variant and this interferon signature. So this is just an example that we did with POMP variants. So we transfected them into a HEC293T cell line. And as what you can see here is we transfected the wild type, and that didn't do anything to the cells, while when we transfected the POMP different variants, so one variant in red and then the other one in green, the interferon signature increased significantly. So this, of course, only works when you have a dominant negative or gain of function mechanism, and you can just easily transfect your mutants into a cell line. But if you have an autosomal recessive model, you need to delete either by CRISPR or siRNA or other mechanisms the protein in your cell line to really be able to do this. So it's easier when there's a dominant negative or gain of function mechanism. So for inflammasomopathies, as you all know by now, there's multiple inflammasomes. They all react to different stimuli, but in the end, what happens is that you assemble, as Alex really nicely showed the video, this wheel-like structures with ASC in the middle, and then activate caspases that will ultimately cleave pro-IL-1 beta or IL-18 into the secreted form and cause inflammation. So this can be measured. This is in yellow ASC, and you can stain for caspase in ASC in patient monocytes. And what you see is ASC specks. So what happens in patients with NLRP3, or in this case that I'm showing here, NLRC4 mutations, is that even without putting a stimuli in these cells, you can see that there's ASC aggregates in patient cells. So this is also, again, pointing to an increased inflammasome activation. Of course, again, then to prove pathogenicity of specific variant in a patient, you need to transfect such variant, being in NLRP3 or NLRP4, into a cell line and prove that this also happens when you transfect the variant versus a wild type, the wild type allele. And this has been used multiple ways. For example, in FMF patients, you can look at ASC specs, and patients with undefined autoinflammatory syndromes, you can also look at ASC specs, and it has also been used to predict a colchicine response. So it can really be used not only for the definition of pathogenicity of a variant, but also perhaps used clinically to help you guide your treatment in specific patients. So unfortunately, this is not yet available clinically, and we really do need to work on to translating all these methods into the clinic. So for proteasome mutations that also cause interferonopathy, of course, we can use the interferon signature as a biomarker. But when we have specific mutations in proteasome subunits, we really need to assess the proteasome. So the proteasome is a multi-protein structure that is structured as a barrel. And these proteasome subunits incorporate sequentially into the proteasome. So if one is mutated, one thing that can happen is that the proteasome will not assemble correctly. Another thing that can happen is that these proteasome subunits, specifically the beta proteasome subunits, have different catalytic activities, and you can also measure those catalytic activities to assess proteasome dysfunction. Again, you can do that in patient cells, but then if you really want to prove pathogenicity of a variant, you do need to do it transfecting the specific mutant into a cell line. And again, this is from our POMP patients. And so this is a control, and you can see this is a native gel, how the different proteasome subunits are incorporated into the proteasome, whereas patients with POMP mutations, that is a chaperone for proteasome assembly, really the proteasome doesn't assemble well, and the subunits are not incorporated into the proteasome. This is accompanied by accumulation of ubiquitin-related products, showing a proteasome dysfunction. And if you do enzymatic assays for proteasome activity, chymotryptic and trypsin activity, this would also be altered when there is a proteasome dysfunction. This is variable for different proteasome mutations, them being autosomal recessive or autosomal dominant. So you really need to assess both the proteasome assembly and the proteasome activity. Moving on to another kind of like interferonopathy-like, but more in the immune dysregulation realm, are the JAK-opathies. In this, just as an example, of STAT1 gain of function, which, as you know, is characterized by polyneuropathy, including type 1 diabetes, vitiligo, alopecia, thyroiditis, cytopenias, enteropathy, and most importantly, mycobacterial and fungal infections. These patients have elevated STAT1 phosphorylation. They also have an interferon type 1 signature and gamma, and this can be visualized by flow cytometry. You can also see that these patients, this is just an example of one patient, but they will generally have an elevated ISG score. So there's two things. you can do in a patient to at least assess them functionally and elevate the likelihood of having of a specific variant being pathogenic. These patients are responsive to JAK inhibitors, but they do require stem cell transplant to manage all aspects of disease, and stem cell transplant results are still not as good as we would like. So sometimes it's important to monitor treatment in these patients. One specific thing for STAT1 gain of function that is important in the flow cytometry assay. So this is a healthy donor and this is a patient. So you will not only see a hyperphosphorylation at baseline, but what you really see is that it does not dephosphorylate. So while at 120 minutes, the healthy donor is almost back to baseline, the patient here doesn't go back to baseline after 2 hours. So this is what really talks about a dysregulated STAT1 pathway. Again, this is in patients, in the patient cells. So this will help you assess this dysregulated pathway in the patient. But if you really want to prove pathogenicity of a variant, what you need to do is to transfect the wild type and the mutant variant into a cell line that does not have STAT1, such as the U3A cells. And when they are transfected with the specific variants, then you can do a luciferase assay to assess for STAT1 phosphorylation. And what you see in patients both in resting and stimulated conditions is that they hyperphosphorylate. So this will really prove the pathogenicity of a variant. For STAT4 gain-of-function variants causing disabling pansclerotic morphia, recently described by the group of Lori Broderick, you can also assess STAT4 phosphorylation, and these patients hyperphosphorylate. And again, using IL-6 as a stimulant, what you see in these patients is that they also they produce also IL-6, and they hyperphosphorylate both in blood and fibroblasts. For STAT3 gain-of-function patients, STAT3 is also downstream of IL-6. Patients have an heterogeneous clinical phenotype with lymphoproliferation, multiple autoimmunity, but mainly cytopenias and arthritis. They also have short stature and unresponsive to JAK inhibition. So this is, again, very important to assess a variant functionally to really determine if this is the treatment you need to use. So as you can do for STAT1, you can use a STAT3 deficient cell line in which you transfect both wild type and mutant and specific mutant, and assess by a luciferase assay, again, STAT3 activity. And what STAT3 gain-of-function patients have is increased activity. Another thing that happens with all these JAK-opathies, gain-of-function disorders, is that when you modulate them, it's hard sometimes to know how much is enough, right? Am I using the right dose of JAK inhibitor or not? And these functional assays sometimes will be useful to monitor this clinically, because you want to take them to the green zone, right? So in this particular case, we used both STAT1 phosphorylation and interferon signature. And you can see this patient, when she was using ruxolitinib, 5 milligrams per day, but then she was not doing well, so we raised the dose, and then she flared. And when she flared and she had a really, really high interferon signature, we decided to up the dose so she was a 2-year-old child. So this is really high dose for a 2-year-old child. But this was the only thing that could help us make the patient clinically stable. So the ISG score was really useful as a biomarker in this patient to monitor treatment. You can also use STAT1 phosphorylation to monitor treatment in STAT1 gain of function. It depends patient to patients if they are the kind that do not dephosphorylate or are hyperphosphorylated at baseline. CXCL9 and CXCL10 may also serve as biomarkers to monitor treatment in STAT1 gain of function, perhaps not in other disorders that are associated to a high interference signature. So clinical assessment is, of course, still key until better biomarkers are developed and available. But in this, like, you can use STAT1 phosphorylation and combined with ISG score to help you monitor treatment together with the clinical assessment of the patient. Of course, when the patient is flaring and on MAS, it's sometimes kind of difficult to decide what you need to do. And in this case, the interferon signature was really useful for us to really decide that we needed to go this up on the ruxolitinib dose to bring our patient to be stable. So new discoveries have led to increased complexity in this classification, and it urges for new functional assays. So disorders in the NF-kappa B pathway are really associated to increased autophagy in TNF-mediated cell death. New disorders have been described causing mainly vasculitis in SICK, HCK, and LIN enzymes. So I don't know of any really functional assays that are available for this pathway yet. But I want to talk a little bit about NF-kappa B mediated autoinflammatory disorders. So as you know, you can have A20 haploinsufficiency, deficiency of the Lübeck complex, and there's this new disease caused by autosomal recessive mutations in Sharpin that also leads to relapathy. So what you can do to assess NF-kappa B signaling, so one way to do it is to use TNF stimulation and look at I-kappa B alpha degradation. So this is also an example of one of our POMP patients where we really thought that NF-kappa B would be downregulated. And to our surprise, when we looked by Western blot, upon TNF stimulation, the patients were really hyper degrading I-kappa B alpha, showing that or suggesting that the NF-kappa B pathway was also dysregulated. But again, this was in patient cell lines. It's only suggestive. Multiple contributors can be contributing to this cell phenotype. So what you really need to do is transfect the mutants in a cell line and look at this further. So we transfected the mutant POMP and the wild type POMP into a cell line and assessed NF-kappa B activity by luciferase assay. And what we saw that was similar to what we were seeing in patient cells was that in fact mutant POMP when transfected into a cell line caused an increased luciferase NF-kappa B activity by a luciferase assay, really demonstrating that these variants were dysregulating the NF-kappa B pathway. And you can do such assays for other mutants in the NF-kappa B pathway as well, but always in patient cells and then transfecting the mutations into a cell line. So this is the new disorder in this pathway. So Sharpin loss of function leads to impaired NF-kappa B signaling. Patients present with fever, arthritis, very severe arthritis of the peripheral joints and also the cervical spine and sacroiliitis. They have excellent response with anti-TNF therapy. And what Dr. Askintihevich identified in these and other patients with mutations in the Lübeck complex was what they really had was increased TNF induced cell death. So she looked at the cell death using TNF, and you can see that all of these patients had this in common. So perhaps, and more is maybe needed to really prove this as a bona fide functional assay for these patients, but this is perhaps a simpler functional assays for disorders in the NF-kappa B pathway. So moving on to another type of immune dysregulation disorder, the functional assays in the CTLA4 LRBA axis really support targeted treatments, because unlike any other disorders, we have a CTLA4 agonist, which is abatacept. So these patients can be we can really do precision medicine for these patients. So it's really important to define if a certain variant of unknown significance is or not pathogenic. So both LRBA and CTLA4 haploinsufficiency are characterized by immune dysregulation with mainly enteropathy. It can have uveitis, CNS inflammation, autoimmunity, and also recurrent infections. They have decreased Treg function and loss of peripheral tolerance, and this is what mediates this autoimmunity. So you can measure LRBA and CTLA4 by flow cytometry, and some patients will have it decreased, but this is not all patients have it decreased, and not having it decreased, at least for CTLA4 haploinsufficiency, doesn't rule out the disorder. So this is just a picture of CTLA4. CTLA4 binds CD80, CD86 to downregulate the T cell response. So what one can do is assess CTLA4 transendocytosis by using CHO cells as an antigen presenting cell that has CD80 coupled to GFP or other color that will be fluorescent. These will be engulfed into vesicles together. So you can see this by flow cytometry, and then will be recycled into again the cell membrane. You can inhibit this recycling using ipilimumab, and this is like the positive control for the assay that I'm going to show you. So what you do is you look at this in patient cells, specifically in the Treg compartment, and you can identify when CD80 coupled to GFP is expressed in the surface of the cells. So this is a healthy donor, and this is the GFP expressed in the patient cell surface. This is ipilimumab used as a positive control, so you can see that no CD80 is expressed in the surface of the cell line. And this is a patient, and you can see here that he's almost as bad as the positive control. So he doesn't have this little group of cells that are transendocytosing CTLA4, suggesting that this patient might have a pathogenic variant, and that might benefit with abatacept. In fact, we did this for this patient. He had a VUS and CTLA4. After this assay, we initiated abatacept, and the patient got better. We're very thankful to Dr. Grimbacher for helping us, providing us the cells to be able to do this assay. And we've repeated this assay for several patients carrying variants of unknown significance in CTLA4. And this assay is a little bit hard to interpret. For example, this patient has a pathogenic variant, and you don't see this, but it's kind of iffy. So what Laura Games and Dr. Grimbacher have done now is they have made some cells with red fluorescence protein that has a really much higher signal and allows better discrimination between healthy donors and patients. But still, this GFP coupled cells were really useful for us to at least suggest pathogenicity of these variants in these patients and really justify starting abatacept treatment. And abatacept treatment is really good for these patients. So this is a cohort of 98 patients with CTLA4 and LRBA deficiency. And you can see here how the spleen completely shrinked, the lungs got better, a neurological lesion also got better. So it's really crucial to decide if variants are pathogenic or not in this pathway to really start the right treatment. ADA2 deficiency is another form of immune dysregulation, where really enzymatic activity defines prognosis and phenotype. So it's really important not only to prove the pathogenicity of a variant, but also to sort of predict the phenotype of the patient. The assay is based on the conversion of adenosine to inosine. We do have the normal variation for ADA2 enzymatic activity, and this is really crucial because, as you can see here, the enzymatic activity is higher in babies than in adults. So it negatively correlates with age during childhood. So you might have you have to take this into consideration when measuring enzymatic activity in patients with variants of unknown significance in this gene. It's very useful to resolve variants of unknown significance. It's also useful to detect carrier versus deficient states. And Dr. Hirschfield at Duke really has measured maybe hundreds of patients and has really established the range of ADA2 activity for carriers and deficient patients, so that it can really help. And as I said, it's useful to classify disease because patients with more severe manifestations will have absent ADA2 activity versus patients with less severe manifestations may have some residual ADA2 activity. And those patients that have absent ADA2 activity are more likely to have hematologic manifestations that really do benefit from stem cell transplant. So a lot of what I've shown you today is from our study called Functional Genomics in Autoinflammatory Disorders that we started in 2022. We've so far collected 130 patients, most of them in the pediatric age. And while for 20% of them, we found a genetic diagnosis, and we've used these functional tests to assess pathogenicity of variants and really been able to establish a diagnosis for patients, there's still 80% of them that do not have a genetic cause yet identified. And we're working on these patients and really interested in studying them and defining the dysregulation of these different pathways to be able to treat them specifically. And this is not unique to us. This number is pretty similar to cohorts worldwide. A lot of patients with chronic autoinflammation and immune dysregulation, we could just not find a genetic cause. So this may be due to different reasons, right? So maybe there's monogenic, of course, there are monogenic disorders that we still don't know. There's somatic mutations in autoinflammatory and immune dysregulation genes that may be hard to detect by our conventional panel or exome sequencing, and more deep sequencing is required. There's also polygenic alterations or epigenetics that might account for these hyperinflammation without really a monogenic cause. So what do we do for these patients? We could use some of these functional assays to assess pathways. Sometimes they're not available. So sometimes we just treat them according to phenotype and according to what we clinically expect to work. And a lot of times the response to therapy will tell us what pathway is disrupted, such as the case when we use anakinra or abatacept in a patient and it works. That may hint us to the pathway that is dysregulated. And this can be used to then go back to the exome results and read them and analyze them to really try to find the needle in a haystack that is a new monogenic disorder. So with that, I want you to take some messages home. So there's more than 130 monogenic defects that are classified as monogenic autoinflammatory or immune dysregulation disorders. And the list is really growing, and it's not making our life easier. The phenotypes are heterogeneous and heavily overlapping. Multiple pathways are also need to be functionally evaluated. Some are common to multiple disorders. And if you're thinking on instaurating some of these assays, you should start, but those that are common to multiple disorders, such as the case of the interference signature, perhaps STAT phosphorylation, etc. Incomplete penetrance is a special complications in these disorders, and you really need to assess them functionally to decide if they're pathogenic or not. You cannot rely just on them being de novo. Genetic testing and functional studies are key to establish a diagnosis and enable personalized targeted treatments. Immune dysregulation forms of inborn errors of immunity underlie in autoimmune disease in a similar way as they underlie infectious diseases. So really rheumatologic and inborn errors of immunity fields are merging. And I think we should think about sequencing rheumatologic patients more often and assess them functionally to establish effective therapies from the start, because the natural history of patients with complicated rheumatologic diseases is that they go from one treatment to another, sometimes more than 15 years without having an effective therapy. And really, if we are able to take these functional assays to clinic, we may be able to treat them better and earlier. So as I said, translation of these functional assays into clinic is needed. CD169 is really good for interferonopathies. It is, though, unspecific, but because it's a simple flow-based assay, you can use it multiple times in a patient and really define who has a persistent high interferon signature. And in the meantime, that these assays make them into clinic, you can always reach out to research labs for help. So with that, I want to thank my team at both the hospital and the clinic that I work at, and especially my research team, without whom any of this would not be possible. And of course, the multiple patients and families that have participated in these studies and enabled us to really develop these essays for them, because that's why we do this. So with that, I want to finish, and I'm open to your questions.
Amazing. This is the reason why I told you I'm your fan. I love it. Perfect. Thank you so much. Amazing. I love it. I think that are so many layers. It's becoming harder and harder to study it. Let's see if we have any questions. I don't think so. Let's see. No, I think that guys are shy. But I have one question.
Sure, Alex.
Have you ever guided yourself in some situations that the patient's not responding to therapy, to change your everything that you started, to change the therapy using some function, I would say?
That's a really, really good question. So I didn't show it here. And we had a really severe patient that presented with urticaria and recurrent fevers in MAS. And we really didn't know what was going on with the patient. We sequenced him. We didn't find a mutation. So we measured everything we could measure. And this is one thing that has been really useful for patients. since we're doing this research study. So this particular patient had a really high IL-18, but most importantly, had a really high interference signature. So in that patient, we chose to combine anakinra with tofacitinib in that case, and it worked for the patient, and he's doing well. He's still on those two therapies for more than 4 years now, growing well. He has developed some lipodystrophy, so hinting that he did have some kind of interferonopathy. But this really helped us to not only start him on a JAK inhibitor on top of anakinra, but also up the dose, as I just showed you with our STAT1 gain of function patient. Because it's hard. It's hard to decide to put a kid on 15 milligrams BID because you don't want to immune suppress them, right? And you don't want to do the wrong
not
thing.
talking about the kid, yeah.
But if a patient is really severely ill and you don't know what's going on, and then the interference signature is 1,000 times high, I think you can be more confident on raising that dose. And then, of course, the patient response will tell you if you did the right thing or not. But it is tough. So thanks for that.
It's interesting because I asked this because I remember a very interesting case that was published by NIH guys. I think that was Adriana. Was a patient with a LRBA syndrome, yeah, with a mutation and everything, like very, very fit. And they decided to start treatment with abatacept, and the patient got worse a lot. And they performed a interferon signature, and what's very high, like very different from what we usually see. And they decided to change the treatment for a JAK inhibitor, and the patient like stopped it with everything. So what's very interesting because that's
a very good point. This has happened to us as well, and so we also have to remember that these pathways overlap. So so having an interferonopathy doesn't mean you only have an interferonopathy. Having CTLA4 haploinsufficiency doesn't mean you only have that, right? So a lot of times, I mean, we wish we had something where we could evaluate all the different pathways and decide what targeted treatment the patient needs. And in fact, when we looked at this for our POM patients, they not only had an interferon signature, but also had very dysregulated NF-kappa B. So we transplanted those patients, so we didn't combine therapies. But I wonder if combining anti-TNF and JAK inhibitors would have been good for these particular patients. But again, it's tough because you don't want to immune suppress them too much. So it can be useful. You really have to be careful when combining therapies, especially. And also when deciding to switch from one therapy to the other, because sometimes therapies are working a little bit, right? And you want to make it perfect, and you change the therapy, and the patient completely goes, bad and not necessarily. So it helps you decide, but it's not the only thing.
It's not so mathematical. So I have a patient that I'm like struggling. What can I do with him? Because he's a patient that with a DADA mutation, ADA2 mutation actually, but only single variant, and tronic one, very pathogenic. But the functional test is a carrier in a level of a carrier mutation. I think it's 40.8, the value. I sent to Duke University. But the patient, the clinic is very different. It's a patient with infections, a patient that I can rule out bleeding in the in brain. So it's hard. Should I treat the patient?
Yeah, you should treat. I'll tell you the answer. So really, patients usually tell you the answer. So if the patient is sick and it looks like DADA2, and you can't find the other mutation, or you don't know what's going on, you should treat the patient. The second thing is, if you look in medRxiv, the group of Dr. Mace has just published a paper, very interesting paper, just not it is only in preprint, but they've shown that some DATA2 mutations are actually dominant negative, have a dominant negative effect. So the fact that you do not find the other mutation in your patient, I don't know what mutation the patient carries, but it might be indicating that so your patient's phenotype might be indicating you that he's really dominant negative and therefore is sick and needs treatment. So you can look into that. I'm happy to share it with you if you
thank you,
can't find it.
Yeah. Yeah, we have
But
here some questions, I think. Interesting. Yeah, we have Fernanda Viana and cheering the presentation, definitely. And Alberto said, thank you both for this long talk. Do you have an experience in your center with functional studies for CARD 11?
oh no, I'm sorry. No, it's very difficult to have a functional essay for everything. So, but the one who has that and is really, really nice person to reach out to is Andy Snow at NIH. So he does that. So really reach out. I mean, I'm happy to help anyone that needs in what we can do. But since these are 140 diseases, it's impossible to have one readout for everything. So really, really reach out to people that are, working in these genes and may have a functional assay that helps you. Also, they might have even looked at your variant and it's just not yet published. And they'll have the answer. You have the answer an email away. So yeah,
No, yeah.
that.
Yeah, we have another question here. Alberto sent, have you noticed that any difference between Ruxo and baricitinib in patient without inflammatory condition that requires them? For example, STAT1-GOF. I ask because we know that most of the evidence is with Ruxo. However, baricitinib has the same mechanism of action and is more affordable.
Yeah, that's a very good point. So I don't have enough experience to like really compare both. I mean, Dr. Mansky, I think, is the one who has more experience with baricitinib, and that has really worked in her hands. And I think the rest of us have more experience with perhaps, both or ruxolitinib and I don't think there's much of a difference really. And also, I think tofacitinib is a really good choice as well. For example, for step one gain of function patients, I have several patients with STAT1 gain of function that have been treating with tofacitinib, and they're doing very well. It seems to be better tolerated. Patients have like less infections, so if they have a milder phenotype, I think tofacitinib is a good option as well.
Perfect. We have here another question from Diana. Which treatment would you suggest for a patient with a SYT variant with a neurological involvement?
This is a very interesting question. So I have not had patients with these variants yet. However, kinase inhibitors that are being used for cancer, and I forget the name of the specific inhibitor, but I can tell you in 1 second that you can use for sick gain of function. So you can use JAK inhibitors have also been used, but you can use, there's a sick inhibitor actually that is called fostamatinib. Sorry, I don't know how to pronounce that. That is used or proposed for cancer that can specifically inhibit SYK. So if you have a patient like that, I would perhaps contact the company and ask for compassionate use of this drug for this particular patient, because it might be hard to get in the clinical setting, but that's one thing you can use. And for Lin gain of function, there's a specific inhibitor called dasatinib that has also been developed for cancer, because this is, all of these kinases are downstream to the B cell receptor. So, and the B cell receptor is really important for lymphoma. So this pathway has been tried to be inhibited for lymphoma. So there's several inhibitors out there that can help inhibit this pathway in these patients.
Very interesting. Fernanda sent a question, and what is your opinion about multiplexed assays of variant effects for autoinflammatory diseases and inborn errors of immunity in general?
Multiplex S of variant. Oh, you are talking about when like you mutate. I'm not sure what the question is, but if you're talking about when you generate the different mutations, so Seth Masters has a recent paper where he did that, and I think it's a phenomenal work that he did. So he generated by CRISPR-Cas like every single mutation that exists in fevers for NLRP3 and basically tested all of them in a multiplex assay, which is a fantastic contribution to the field. And like, I really admire his work. It is very expensive. So we'll have to wait for Seth to do it for every single gene. But I mean, that's phenomenal because like, we don't need to test any NLRP3 variants anymore because he tested all of them. And it's I mean, if there's a variant that he doesn't have in there, you can call him and he'll run his multiplex assay.
Yeah.
So I think it's a fantastic way of solving this problem. It's still perhaps too expensive to for us, at least for us in Chile, and I suspect that is the case in the rest of Latin America.
Actually, this is a point, Ara, that I would like to ask you about the access of medication, how it works for you guys there, because we know that it's rare diseases. In Brazil, if there's not a code of the disease, there's no exist. So how to get these medications?
It is very difficult, and it's perhaps harder in Chile than it is for you in Brazil because you are more people. So you can always advocate easier to companies. So for us, it's the same. So we have specific programs for systemic GIA, and sometimes we have to call our patients systemic GIA to be able to access treatments. It's very difficult. A lot of our patients end up, suing the system or suing their insurance to be able to get the medications. They're very expensive. So this particular patient I was telling you about that we had to use anakinra plus tofacitinib. It was crazy expensive. So he moved to Spain and so got the treatment. So it's difficult for us. I don't have a recipe, solution for that.
The same thing,
unfortunately. So I love this field, but that's one frustrating part of it, that I have to be like all the time writing letters for the insurance and to the government.
But even with normal, if I can say it's a bad word, I'm sorry. Even with common diseases like asthma, for example, we have a lot of problems here in Brazil with the medication. Are there, we can prescribe it, and we have a lot of issues with the health insurance, for example. So it's hard.
No, I agree with you. I think it's a problem everywhere, even in the US. Insurance is really tough. In Chile, we have a lot of problems.
And I see it a lot because I work in an infusion center. So even the patients that come to the clinic to use some medications for other colleagues, I can see they struggling a lot. So,
But because I'm already old enough to have seen some progress, and I think Magda's here, a lot of more senior people that are here will probably hear what I'm saying. We didn't have gamma globulin covered 20 years ago. So now we have that. Now we have better treatments, but there's sometimes a gap between you have all these fancy targeted treatments and they make it into clinic and then they are covered. And I think that's another function of all these functional assays, because when you have a functional assay and you can really demonstrate inflammation, pathway dysregulation, you can go with that to the insurance or to the government. Of course, they won't know what you're talking about, but you can
Yeah.
argue with them and say, well, the patient has 1,000 times interferon signature and really needs a baricitinib or Ruxo or whatever you need to use. So these functional assays really, really help for that. I mean, you have to write it down and advocate for it, but they do help, especially when we have to raise the dose, for example, because they won't cover
Yeah.
the dose raise. But if you say, hey, this is a pathway we're trying to inhibit, and look at this essay, and these are the papers that support that what I'm doing is the right thing, then that might help you advocate for an increased dose or for a specific treatment.
Perfect. Yeah, I do agree with you. Ricardo sent a question. Yeah, and congratulations, definitely. About some general policy about vaccine. So would the reaction to the vaccine give you a clue in some, I think, I don't know, it's about hyper IgD syndrome or another disease that can work with a hyperactivation after vaccine? I think it is. It's about this.
I think that's really non-specific because patients with SIRF will also react to
Yeah.
vaccines. Um, I have patients that are completely healthy and also react to vaccines.
Yeah, and they
So I
activate.
don't,
Yeah.
yeah. So I don't think that, I mean, by the time you have a bad reaction to a vaccine and you're thinking that that is going to be related to an inflammatory syndrome, you should also have all the other things that are pointing into an autoinflammatory syndrome. So I wouldn't use that as even a criteria. I mean, it just,
But do you have
adds
any
to everything.
orientation to the patients, like you're using the medication, so do the vaccine near to the next infusion or something like this?
Oh yeah. So for example, for CAPS patients, I generally, may up the dose of like anakinra or may. So you want the vaccination to be the closest to their dose because they'll
Yeah.
reactivate. They may need like an extra anakinra dose if they vaccinated. They definitely should be vaccinated because otherwise they're going to get an infection and they're going to be reactivated anyways, right? Um, so that's one thing you could do. You could also use steroids, right? If in the poor world,
Yeah.
right? But yeah, you do have to take that into consideration when vaccinating these patients.
Perfect. Awesome. Let's see if you have more questions. No. Only compliments, definitely.
Yeah.
Dr. Magda
Well,
send congratulations. Fernand again. Gabrielle, let's see. Yeah, only compliments. Yeah, it's
oh,
nice.
well, thank you very much, everyone, for joining this late at night. Thank you, Alex, for moderating, for presenting your
Oh,
excellent
it's a
case,
pleasure. Yeah, I'm very
and
happy.
the
Thank you
company.
so much. And thank you, Carol. Carol is turning back with us now just to say goodbye. And I'd like to thank you again so much for your invitation. It's a pleasure to me.
Thank you, everyone.
Thank you.
Bye.
So I think we have two more announcements here.
Oh,
So the two next webinars, we have the LASIK Juniors webinar, July 10th. It will be about SOX1 haploinsufficiency. And then by the end of the month, we have our LASIK webinar talking about incomplete penetrance. So we'll be discussing about like why some patients with the same variant in the same gene, some of them have clinical manifestation and others don't have or have a milder phenotype. And for this, we'll be counting with the talk from Dusan Bognovic. He's from the Department of Pediatrics in Columbia University. So we hope you all can join us for both webinars. And don't forget to register for our LASIK meeting. We hope to see you all in Buenos Aires in October. And send your abstract, submit your abstract before June 30th. So thank you very much. Have a good night.
Good
thank you.
night.
Thank you,
Bye-bye.
Caro.
Thank
Thank
you,
you.
guys.
Bye.
Bye.